I'm sure it's going to be interesting. وبدنا الميكروفون. تفضل.
شكرا دكتور إياس. Can I have the slides? Okay. So this is a 65-year-old woman who's hypertensive on beta blocker. She's not diabetic. There's no history of smoking or dyslipidemia or connective tissue disease, no non-thyroid disease. She's been complaining of shortness of breath for a few months, and she was treated as chest infection. In the absence of response, a chest X-ray was obtained, and the treating physician saw a large cardiac silhouette. So she was referred for an echo to another place. It showed large pericardial effusion. She had pericardiocentesis 1 month elsewhere. There was no diagnosis and no improvement. In the clinic, she did not come to the ER, she came to the cardiac clinic. She was dyspneic on minimal exertion. There was no cough or fever. She had hypotension, heart rate was 70 because of the beta blockers. She was tachypneic with good oxygen saturation on room air. She had distended neck veins, distant heart sounds, and the EKG shows normal sinus rhythm with low voltage, but no ST changes or Q waves. The echo shows large pericardial effusion, about 5 centimeters, with fibrinous strands, thick pericardium, and some degree of RV diastolic collapse. The LV size was normal. She had mild concentric LVH. Ejection fraction was normal. There were no wall motion abnormalities. There were mild mitral and tricuspid regurg. So she was admitted to the ICU, and in a few hours she had pericardial window, reported as uneventful. Initial drainage was 700 cc of lightly bloody fluid, and when she arrived to the ICU, there was another 1 liter of lightly bloody fluid. The post-operative course, she was alert-oriented. She was on oxygen mask, good blood pressure, increased. Heart rate, 100 per minute was sinus. She was on IV fluids. 1 hour later, we were called to see her because of severe dyspnea, and she became restless. Blood pressure started to come down. She became more sinus tachycardic with desaturation. Abdominal exam was okay. A portable X-ray shows white lungs. The EKG was repeated, no new changes. Troponin was positive. And these were the labs that came pre-operatively, they were fine. We repeated the echo and showed LV mild dilatation with generalized hypokinesia. Now the EF is 25%, systolic PA pressure was 55, there was less effusion, and the RV collapse has gone, the valves were okay. So the question to the fellows, what is the most likely diagnosis at this stage? Is it A, a massive PE, B, an acute anterocipitال wall of eye with VSD, sepsis, Takotsubo syndrome, or none of the above?
None of the above.
None of the above. The intensivist, despite the clinical picture doesn't fit PE, but there was a CT pulmonary angio ruled out pulmonary embolism. Acute MI, I think it's ruled out. There was no murmur from the VSD, no wall motion abnormalities. The LV was generalized, hypokinetic, etc. Sepsis, she had cold, clammy sweats. She was hypotensive. There was no warm shock. Takotsubo, as you know, is a diagnosis by ST elevation followed by normal cath, and then the LV will not show just hypokinesia, will show a ballooning of the apex. So again, it doesn't fit. So you are right, none of the above. But what is none of the above? Is it A, intraalveolar bleeding, tension pneumothorax, adult respiratory distress syndrome, or again none of the above?
None of the above.
كمان مرة؟ طيب. أنت معاذ تحكيش. Okay, so actually yes, because again, intraalveolar hemorrhage, when she was intubated, there were clear fluids and no background history of what predisposes to this. Tension pneumothorax, that she has white lungs. ARDS cannot be diagnosed when the LV dysfunction is severely impaired. So what we have here is we have an acute LV failure after pericardiostomy with no explanation, right? Do you think of anything, any diagnosis we should do before we jump to the diagnosis? Pulmonary, cardiac, aortic dissection, PE, MI, tension pneumothorax, bleeding, whatever. So this is the diagnosis. This is pericardial decompression syndrome. This is a rare but potentially fatal complication of pericardial drainage. has to be recognized and prevented. And actually, the term was only published in 2010, so it's only 5-year-old syndrome by Angoras. It is acute cardiac failure that develops after pericardial drainage for tamponade mostly. The syndrome has no uniform clinical presentation. So it can be maybe associated with surgical pericardiostomy or just what we do, pericardiocentesis. And the cause of the pericardial effusion varies. In the literature, in 83 to 2013, there were only 35 cases published. And in 18 cases, it was what the cardiologist does, and in 16, it is what the surgeon does. Sometimes one had both, one case. There is limited epidemiologic data. The incidence is less than 5%. However, probably some of you had this complication, but we could put any potential diagnosis, but this is the name. 60% had a previous history of malignancy, and 40% actually had neoplastic etiology. Cardiac tamponade was indication of most of the cases, but sometimes you just drain it to relieve large effusion, and the mean amount of the draining fluid was less than 1 liter. However, it can be seen in just draining half a liter of pericardial fluid. 1/3 present with acute heart failure, and 2/3 actually what happened with our patient. She had cardiogenic shock with hypotension, and 80% will have elevated troponins. Mortality rate, however, is very high. You lose 3 out of 10. And actually, the reported cases of death were confined to the groups that were reported due to surgical decompression. What is the pathogenesis of pericardial decompression syndrome? This is the unexpected or paradoxical hemodynamic deterioration. You have a patient who is in tamponade, blood pressure is borderline, almost shocky, and you expect that everything will improve hemodynamically, and then he comes to you from the surgery with cardiogenic shock. So there is some background ventricular dysfunction. Sometimes there is some malignant myocardial infiltration or history of chemotherapy that induces cardiomyopathy. So there are a lot of pathological mechanisms in the absence of one etiology. Ischemia, there might be persistent diminished coronary perfusion from the pressure of the fluid, and the ischemia doesn't resolve with removing the fluid. And there is the theory of autonomic imbalance hypothesis. However, the mostly accepted hypothesis is the hemodynamic hypothesis. Now, what happens is that when you remove the fluids from around the heart, you increase the venous return from the superior and inferior vena cava. So what happens is that there is enlarging of the right ventricle and paradoxical pressure on the interventricular septum with compromise of the left ventricular cavity. Subsequently, patient will have a small, like what we see with hypertrophic cardiomyopathy, very limited LV cavity, and the patient will have LV dysfunction associated with hypotension and generalized hypoperfusion. Add to that possible myocardial stunning, diminished pericardial perfusion due to, as I said, fluid compression and or pre-existing ventricular dysfunction, plus the sympathetic stimulation following the removal of the tamponade. Now, why there is high mortality? Because basically this is selection bias. Probably some patients will have milder degree of the syndrome, but they recover, and we see probably just it is a complication of the procedure, the anesthesia, some coronary disease, and it resolves, but definitely it is a diagnosis of rule out. So what is the proper treatment? Is it pulse steroid therapy or intra-aortic balloon pump, urgent cardiac cath, or supportive treatment? It is definitely supportive treatment. There is nothing in particular you can do, but how to avoid it, this is a question. Do pericardiocentesis rather than window. Drain 100 cc initially and then 100 cc per hour. Start dopamine high dose prior to the procedure. Prophylactic balloon pump prior to the procedure, or cannot predict. كل الأسئلة اليوم آخر choice. So PD can the syndrome can occur with drainage of less than half a liter. There are no published data to propose preventive measures. However, what the author of the analysis showed that the reasonable approach is to remove fluid until resolution of tamponade by hemodynamic features, blood pressure start to come up. You can slow the removal of the fluid slowly, and then you keep the drain until there is about a daily back flow of about 30 cc per day, and then you can remove it. Just to follow up on this case, the patient was given oxygen diuresis inotropic beta blocker later on. She had rapid diuresis, 24-hour on the ventilator, and then she was fine. The fluid came back as hemorrhagic. There were post-viral features, however, we could not find any malignancy, and the tissue of the pericardium showed just chronic pericarditis. That was in April. She was seen last month with normal left ventricular function. Thank you so much.